This episode of PharmacyToDose, the Critical Care Podcast, is proudly sponsored by Chiesi. Chiesi is a family-owned, research-focused, sustainable pharmaceutical company accredited with both B Corp and a benefit corporation status. Chiesi is making global changes that benefits patients, providers, and healthcare organizations with forward-looking and impactful initiatives. Chiesi appreciates the integral role that clinical pharmacists play in patient care and are proud to support this community. To learn more, visit chiesi.pharmacytodose.com. Again, that's chiesi.pharmacytodose.com. Welcome to Pharmacy to Dose, the Critical Care Podcast. And I'm your host, Nick Peters. And wherever you are and however you are listening, thank you. It's a jam-packed episode today as I'm joined by Jason Vilar, neurocritical care pharmacist, to get back into status epilepticus. Part 1 was one of the first episodes ever done on the Pharmacy to Dose pod, and part 2 of the discussion resumes today into this neurocritical care disease state. So Jason reviews some general status epilepticus treatment principles. We pick our favorite landmark articles before our discussion shifts to refractory and super refractory status epilepticus. How are these terms defined? What's our treatment approach? How do we dose these agents? How do we think of them differently from our normal kind of PAD-IS or other indications? What are medication safety things to keep in mind, both from a operations and clinical perspective? Do we have preferred terminology? Much more. Another quick reminder, 2024 Pharmacy to Dose Award nominations end Friday, August 31st. Submit yours today. But let's get into our neuro-themed episode with Status Epilepticus Part 2, starting right now. Very lucky to be joined by today's special guest, Jason Vilar. Jason is a neurocritical care clinical pharmacy specialist at Advent Health Orlando. One of my favorite Twitter handles in some time, The Brain PharmD. You can find him. Jason, welcome. How are you, man?
I'm doing wonderful. Thank you for having me. I'm super excited to be on the pod.
How did you think of that handle? That's that's very funny. Every time I see it, it makes me chuckle just a little bit.
You know, working in neuro, I had to do something related to that, and it kind of just fit. So the tag along with it is I use my brain to save yours. So I thought it was fitting.
Oh man, that's even better. There needs to be a way to somehow see that byline in the handle, because that just makes it somehow even better. Listeners, this is Status Epilepticus Part 2. So one of the first episodes we ever had was Status Epilepticus with Corinne Berger. We focused more on the initial general management, disease overviews, and this episode's going to focus more on refractory, super refractory status epilepticus, but also other changes and highlights, and work to cover things that basically we didn't have time to or didn't have the info for yet to discuss on the first part. So a lot of that's still pertinent. Be sure to go back and listen to that. But part 2, while we're here today. So Jason, what's the prevalence of status epilepticus, like the morbidity and mortality rates? Like, why is the care of these patients so important?
Now, in regards to status epilepticus, it's not something like, your ischemic strokes or your coronary artery diseases for what it's worth, but it is fairly common in the neuro ICU to see these patients. What we see typically is anywhere from 12 to 1 per 100,000 patients, depending on the classification of status epilepticus. It's really important that we consider this a medical emergency because the risk of subsequent epilepsy after each of these events and as it progresses can go up to almost 90% if you get to progression of super refractory status epilepticus. And moreover, these patients do have significant morbidity, specifically any sort of neurological sequelae at 3 months. For those that do survive, up to about 80% of those patients will have some of those neurological damages that lead to some significant morbidity. And then, unfortunately, we do see a profound amount of mortality in patients that develop super refractory status epilepticus. Almost 3/4 of patients that do get into this particular progression of the disease state do unfortunately die. So it's really important that we treat this as a medical emergency, and that's why it's really important that we take care of these patients in this manner.
So, definition of status epilepticus: 5 minutes of or more continuous clinical and or electrographic seizure activity, or current seizure activity without recovery to baseline between those episodes. So you mentioned refractory and super refractory status epilepticus. So how are those defined under that umbrella?
So, with this particular disease state, there originally, like you had mentioned, there's clear-cut definition for status epilepticus. It's a little bit more clear now with refractory status epilepticus. This can be defined as seizures that are persisting after an appropriate dosing of one of your emergent medications, and then also after one of the urgent therapies. So essentially, two anti-seizure medications. As far as the distinction, there is subgroups actually associated with refractory status epilepticus. There's a newer distinction called, let's say, NORSE, or new onset refractory status epilepticus. This was recently described in 2018 and defined as a clinical presentation in patients without active epilepsy or other pre-existing neuro disorders with refractory status epilepticus, without a clear or active structural, toxic, or metabolic cause. I know it's a mouthful, but essentially it's a subgroup saying, hey, we don't know why they had this, right? And then furthermore, which is a little bit more vague, is the super refractory status epilepticus. This can be really contingent on the type of publication or the publication that you're reading, but most will define it as a seizure that persists after 24 hours of initiating that continuous IV anesthetic agent, or possibly those that do recur once you start weaning that agent.
Status epilepticus doesn't feel like a new disease state, but when you look into the refractory and even defining our super refractory, you start to realize that it's actually much more modern and common, those later ones like that. Those aren't old definitions. Those are fairly new.
Yeah, I mean, I think there's still a little bit of debate whether or not to have time constraints associated with that versus, interventions that were attempted. I know one of those things that we're still considering for a lot of our neurological population, regardless of the disease state, does become involved with, or I guess, integrated with time as an association. So I think that it kind of leans a little bit more towards including in some of the definitions, if that makes sense. But yeah, so these are more modern in our times, actually.
So do we know why patients develop refractory or super refractory status? Have we identified risk factors that have the higher chance of progression?
Yeah, really what it comes down to, we really don't have a clear-cut answer to this. There are a multitude of reasons for progressing into either refractory status epilepticus or super refractory status. Really, the underlying cause can be the most concerning component, but it comes from a pathophysiological standpoint. The brain actually does physically change as you progress with these uncontrolled seizures. So what happens is, as the seizures progress and they go unabated, there's constant neurostimulation. And what happens here during this time frame is there's actual structural changes leading to the trafficking of our downregulatory inhibitory receptors, specifically GABA in particular. And what this is internalization. It ultimately makes this more difficult to control. Many of our anti-seizure medications do work at this site of action. And essentially, this becomes a vicious loop where you have this downregulation of inhibitory receptors and this upregulation of neurostimulatory receptors, glutamate, or specifically like things like NMDA.
Thing that also stood out to me, one of the things that made me kind of look into the super refractory status disease state was this JAMA neurologic systematic review and meta-analyses that kind of combined all the data to try to find things. And, 40% of them due to acute cerebral events makes sense. 22% completely unknown, right? That was the thing that stood out to me. The second most common reason was we have no clue. There was no precipitating risk factor. And that's kind of what's scary with this, to be honest.
Yeah, it's a clinical conundrum why this happens still, unfortunately. And that's what makes it interesting as well.
The common presentation most of us think of when discussing seizures and status epilepticus is this convulsive seizure, right? The tonic-clonic. But how else can these patients present?
I remember when I first started learning about seizures and convulsive status. This is something that you think of the movies where you see that person freeze up and then start jerking, the tonic-clonic and shaking, right? Obviously, they can present in that manner, which makes it a little bit more clear that something's going on. But there are patients that actually can progress in a much more subtle fashion. And even as such, those that do have a clear presenting convulsive status epilepticus episode, they can come into a more subtle progression into non-convulsive status epilepticus. Up to 20% of patients that do have convulsive status epilepticus can progress into non-convulsive status epilepticus. Essentially, what this is status epilepticus without any prominent or clinical obvious motor components. They even might have zero motor components associated with it. A lot of ways that this can possibly manifest is something like facial twitching. I often see very, very subtle lip twitching, hardly noticeable if you're not looking for it. And even when you're doing a neuro exam and you're looking at their eyes and doing an eye exam, you'll see some roving. Those are some subtle little things that actually might suggest that this patient might be a non-convulsive status epilepticus.
And that's why the requirement for a clinical and or electrographic seizure activity. And we'll kind of get into EEG monitoring and why that's so important. So there's been kind of a shift in the tide in the pharmacotherapy terminology, I guess you'd say it. What's our preferred phrasing when we're talking about status or status epilepticus pharmacotherapy? Is it AED or ASM, and why?
That's a great question because for when I started practicing, it was always considered an AED, right? And I mean, that technically in the realm of medical terminology can be considered something else, right? But for the most part, I can often say that I fall victim of using AEDs just from my past. AEDs being anti-epileptic drugs, but the terminology now has shifted towards using anti-seizure medications or ASMs because many of these patients don't necessarily have epilepsy. And so you're just treating seizures. Now, that's not to say that they might not develop epilepsy, but right now you're just trying to terminate the seizures as it stands. So ASM is going to be the preferred terminology nowadays.
All right. Thanks for keeping us straight there, Jason. I agree. I slip sometimes, hand up. I promise, Team ASM, we're trying our best. Now, just to clarify, this always kind of confused me. Our first line treatments, our emergent treatments, right? Benzodiazepines, are those considered ASM's anti-seizure medications?
Yeah, I mean that's very confusing because we'll use it for agitation, we'll use it for withdrawal, things like that, right? And we classically associate cessation of a seizure with anti-epileptics. Hence, again, why we're moving towards ASMs as the terminology, because this can be and is considered an anti-seizure medication because it is a first-line agent that works by terminating seizures at agonizing the GABA A receptors, and so thereby using this as an agent that terminates it, it is considered an ASM.
Okay, full circle. So that's even more important why the name change matters. So the listeners know my toxic trait, I like to rank things. It's just in my blood. So we're going to make our four favorite, our Mount Rushmore of landmark status epilepticus literature. So Jason, the guest, will get to pick the first two, and then I will I'll pick cleanup on the other two. So Jason, what are your two, and then just kind of briefly why are those two kind of the favorites that stand out to you?
Okay, so the there are limited ones that I would say that are like must-haves.
Yep.
And I'll work from, I guess, earliest to latest. The one that I'm gonna pick because I just tend to like it and see the clinical nuances of it is the Rampart trial. And this was essentially the trial that looked at IM midazolam versus IV lorazepam in terms of seizure cessation. And this was pre-hospital, right? And so I think this is a very important study for a multitude of reasons, right? I think it highlights the fact that time is everything. At the end of the day, you might have had a clinical difference in terms of a 10% cessation difference of IM midazolam, but that's likely the fact that these patients did receive the agent a lot more quickly because you don't have to get IV access, right? And we could talk about that a little bit more, but in reality, what it comes down to, it says if you dose it appropriately, and maybe you'll talk about what the dose is and the studies that develop those. If you dose it appropriately and you give it fast, you're going to get what you need. And so that's why I really like the Rampart trial.
Yeah, and done by the Neurologic Emergencies Treatment Trials, the NET network, setting up the ESET trial. So not only was this, that was my number one pick, by the way. That was the number one pick in the pool, I feel like. So that was strong work there. All right, what's your number two pick?
You just mentioned it, right? So the ESET trial it has to be the number two pick, real close to the Rampart, because unfortunately, with this disease states and the trials that we have available, they haven't been the greatest, right? This was the first recent trial that was randomized to break down essentially what agents are going to be better than one another in terms of urgent therapy, that second line agent. Once you can't really break that seizure up front in status epilepticus, what can I use? Can I use the valproic acid? Can I use the phenytoin or phosphonatoin, or can I use the Keppra? Now, ideally, this was going to tell us which is, going to be the agent that we should all do. Unfortunately, we didn't get what we really wanted out of this trial. There were a lot of confounders that didn't give us the answers that necessarily what we would have hoped for, really. Right. So what we found in the SET trial, and I'm not going to go into too much detail because I believe we talked about it in the previous pod, is essentially that we're not great at giving benzo doses. Right. I think 30%, if I remember correctly, only 30% received appropriate dosing. Right. And even there, I personally believe that appropriate dosing, and I'm putting this in quotations if you can see me, because if you think about appropriate dosing, the dose caps for benzodiazepines are rather low. Essentially, you're capping all of us at 40 kilos. 40. And I don't know how many 40 kilo patients we have out that are adults. There are a few, maybe cerebral palsy patients, right? But those are few and far between. And so if you're not even achieving those types of doses, you're probably you're going to have a lot more difficult seizures to suppress. And on top of that, I think the dose caps to blind the urgent therapy, specifically phosphonatoin, really limits the loading doses that we're using. So I don't know if we're actually getting the differences that we would have seen had we used true appropriate dosing, unfortunately. But it does tell us that there is not any difference between the three agents that are recommended. And so it becomes kind of a dealer's choice. And also, that dealer is taking into consideration a multitude of things, but it says really we can choose one of those three agents.
That's how I thought this was going to go. You went chalk 1-2, 100%. All right. Now, my two studies, I would say my takeaways are benzo dosing. So my number two pick, it's an oldie but a goodie. The 1983 JAMA study comparing lorazepam and diazepam in status epilepticus, finding, so these patients got 4 milligrams of lorazepam, 89% seizure control. 10 milligrams of diazepam, 76% of seizure control. Adverse effects in less than 15% of the patients. So it's kind of the first big study that kind of set the stage for our lorazepam dosing. So I was like getting one of like the oldies. So that's my number three pick. Was that an expected choice from your perspective?
Absolutely. I mean, that was the game changer that set the stage for the future studies, and it's the staple of therapy, really. And it's kind of weird that we still don't even achieve that, unfortunately, for a good chunk of our patients.
Yep. And then the next study, probably also an oldie, just way less oldie, the 1998 New England Journal of Medicine, the VA co-op study, the comparison of 4 treatments for generalized convulsive status epilepticus, basically showing that the lorazepam 0.1 mg per kg was significantly superior to phenytoin treatment, setting up essentially our emergent pathway that benzos and specifically IV lorazepam being our first line agent. So was that your 4? Did we kind of have the same? We didn't plan on this for the listeners. There was no collaboration here, but would those have been your 4?
Absolutely. There's no question for those 4 agents or 4 studies rather. Sorry. Um, they're exactly the ones that I would expected to hear from you, to be honest.
So Jason, when we're thinking of emergent treatment, we talked a little bit about the benzos in those studies. We'll get back to those. Let's put a pin in that. But in terms of our other emergent treatment options, what we would have classically referred to as AEDs, but our other ASMs, you hinted at this in the ESA trial, but do we have a first line option or a recommendation on any of our kind of big agents?
No, we unfortunately don't. I would have really liked to have seen something come to fruition, but it really comes down to a lot of things between those 3 agents, of course. And that's taking into consideration provider preference, comfortability. We'll talk about a little bit more operational components too. It depends on your institution. We talked about a lot about time to therapies. And so you need to take all of these types of things into consideration: drug-drug interactions, drug disease state interactions, the historical context of this patient. So a lot comes into play when selecting these agents, but there isn't a clear-cut answer based on the set trial and the previous trials that we've had to date, unfortunately.
I will say I always find it, I understand why we don't use them, but I find it's kind of the under talked about in both guidelines, the 2016 uh, the 2016 American Epilepsy Society guidelines, and then the 2012 Neurocritical Care Society. Phenobarbital is listed as as an emergent treatment. And I don't think it gets the love. I understand the side effects with it, but I don't think it gets the love that the guidelines kind of show it, and clearly that the evidence may show for it.
Yeah, I think it does have a role for sure. And correct me if I'm wrong, and I'm not too keen on the pediatric population, but I believe that there is some data, stronger levels of data with barbiturates in pediatrics. I could be wrong though. Um, and it makes sense. I mean, with GABAergic activity, right? So it's a different modality, mind you, it could work. And so that's something that makes sense if you're doing a dose that's especially a linear kinetic type of model. You can get exactly what you'd expect from a target concentration. So it's a TDM medication. You can measure levels. It's really easy to dose. And you know what? It's easily accessible for most cases. So that makes sense. It's something that probably is a good thing to keep in your pocket, in your wheelhouse.
So probably more of a first line question for our EM providers and pharmacists, but how does their home medication use affect your initial ASM choice? Because I kind of think it's the same like AFib, right? Where some people think, and for this, I could see the argument, if they're on this at home and it controls it, we should continue it. Also see the argument that would make sense of, well, they're on it at home, it didn't work, we should use another agent. So is there guidance to say we should use one of those strategies over the other?
Man, that is a great question. And it comes up a lot, especially even in prophylaxis. But in the
Oh, yeah,
setting
yeah,
of,
yeah.
yeah, definitely. In the setting of status epilepticus, I think it's important to understand the history by which they come in if they are already on an ASM, or in this case an AED, because they were on an epilepsy medication for them, right? And so is it compliance? were you able to get a history with family members or a group home or something saying, hey, maybe they didn't have access, or maybe they were really sick or vomiting, and something that made sense that, hey, this is a compliance concern. Let's just stick with what we know works. It historically has worked. Let's just reload them. Maybe we get a level to check test compliance, right? Maybe we have therapeutic drug monitoring that's associated with those. Unfortunately, when time is a major concern, these values don't come back to us rather quickly. So, like, if it was a perfect little bubble and you could say that it would, poof, you get the answer and you get those levels, then you can base it off of that. Unfortunately, you're probably going to have to stick with your guns and do a good old med history and talk to someone really quickly. And if you don't get the answer, load them hard and then load what they usually used. I'm okay with that because the rapid progression throughout the drug selection should be already in the back of your mind as a pharmacist. The EM pharmacist I know I work with already has that second agent in their mind, right?
Second, third, they're probably thinking,
yep.
They're probably planning for the crike too when they're going to have to intubate, right? They're thinking of everything.
They're 3 steps ahead.
So the other thing kind of when we're thinking of the acute phase is managing drug-drug interactions, because I think every student knows, right? You get the new patient, you put all the drugs in the interaction calculator. And on this status epilepticus patient, you get like 4 class D interactions. You're like, wait a second, what's happening here? So how is there guidance as to like, oh, in the acute phase, maybe it's not as big of a deal? Or how do we kind of use our drug-drug interactions to help influence our choice or maybe agents not to use?
It is important to take into consideration the agent that you're going to select, right? If you're starting with your emergent and urgent therapies. Subsequent agents that you're going to use is going to be very important thereafter. So, for instance, one of the things that comes to mind as a pharmacist that I see that makes me want to just, cry a little bit is when we see an order pop up for valproic acid and fosphenytoin, right? Both these agents great individually, right? We don't know the differences between the two. We dose them appropriately, but when you see them together, that can cause major issues. And that's because these have profound protein binding competition. And so no one is going to get perfect levels with these. You can get all the levels that you want, and then they're going to be highly variable. Not to mention it takes some time to get certain types of levels. If you're trying to get free levels, then that's another story. But yeah, you have to take that into consideration, right? Eventually downstream, once you get to more of those like second, third line, fourth line, depending if you're in super refractory, there's going to be even more drug-drug interactions that you're going to have to take into account. So really what we take into consideration when taking account for drug selection is you need to start thinking about who is the victim or the perpetrator, right? And who is the one that is actually inducing or inhibiting. So I think I like to think about your enzymes. You think about which one is the substrate, and then which one of these agents is going to be the inducer and or inhibitor, and just take that into consideration when you're selecting agents. But most importantly, don't select something that is not going to allow you to get therapeutic concentrations in a more stable and consistent fashion.
Let's talk about those therapeutic concentrations. So the era of personalized medicine, should we be avoiding agents that we can't utilize TDM in? Classic one that comes to mind, right? Keppra, levetiracetam. You might be able to, the level's not going to come back in a timely fashion. Even if it does, other than compliance, it's not going to tell you much more than that. So how do we balance that of being able to monitor and get our target concentration versus maybe the other drug has more evidence behind it?
Yeah, man, this is tough because I'm a fanboy of levels in general, right? Like I genuinely think, especially in the realm of critical care medicine, when things are hyperdynamic or maybe very slow in terms of metabolic processes, it's always varying, right? Your hepatic function, maybe you have increased AST/ALT, TBL, and your hepatic function has gone out the window. Same with your kidneys, you're not clearing things very well. Maybe you're hypoalbuminemic. All these things are going to take into consideration. And so it lends favor to something that you can actually control, but really there isn't any sort of data to say, hey, just because you can monitor it, it's going to do better, unfortunately, right? Now, if I had the ability to say each of these had therapeutic windows and I can monitor everything rather quickly, I would probably lean to something that has a very wide spectrum of activity, right? A very wide therapeutic indice that has limited drug-drug interactions. And so I tend to lean on something that I can have less effect downstream, and I'm going to go add something else later on, something like a lacosamide or a Keppra, right? Those are going to be things that I'm okay with, even though that I don't have necessarily therapeutic concentrations that are routinely available and useful. I'll say that's okay, and I'm just fine with that.
Yeah, you hit lacosamide. I think that kind of leads into the next thing because rapid administration is so important. We highlighted on a previous episode rapid IV push administration of Keppra. So are there other ASMs that we can give rapid IV push, which would obviously be a huge check in the pro column for their use in the acute phase?
Yeah, I mean, there are actually a lot of agents that we can give in a push fashion. And the importance of this is the operational components of this, the accessibility of this, and time to administration, as we had previously mentioned. And so there has been clear data to support IV Keppra pushes, and that is very common now. I'd like to say that more often than not, many providers have heard about this and have even implemented it in their practice. It's still something, as a work in progress from some centers, but I think that people are very familiar with the levetiracetam push dosing. As far as other agents that are available, the lacosamide, it would be a nice option. Now, this isn't technically one of the first line agents that you're going to use of the big three, but it is a potential option if one of those do fail and you have that in your Pyxis or your automated dispensing cabinets, right? It's important to recognize that you can technically give other agents like phenobarbital. We mentioned, right? That's a fantastic agent if push comes to shove. There's even IV formulations of Briviac that are available. Fosphenytoin, yes, you can technically push it, but at the doses you're giving, you're not going to be pushing it unless you want to see someone have a cardiovascular collapse. I don't know.
Yeah, if you believe that your nurse is pushing that over 15 minutes, you are either the most trusting. I got some ocean front property in Arizona for you, right? Because it's just not happening. Yeah, that's a really good point that technically you can. Just because you can doesn't mean you should.
Yep. And so I think, yeah, just to that point, it's important that there are options to use outside of just the levetiracetam, like glucosamide and phenobarb. It's just important as much from a safety perspective to consider the rates. And so I'd like to jump back for the Vimpat, the glucosamide. The data suggests that you can push up to 80 milligrams per minute safely. So those are some of the things that take into account, along with some of the other adverse effects that are associated with like PR prolongation. So maybe you have someone with a cardiac history, right? That might not be the agent that you jump to right away. Maybe they have some sort of block that you're seeing on the EKG when they come in. And then something like the phenobarb, someone with very soft blood pressure, you might want to, go towards the slower administration if you're going to use it. So some of those considerations to take into account when you're using IV pushes.
Yeah, two things I want to highlight. You talked about those issues when you were getting drug levels of like hypoalbuminemia and things like those are all very common things, right? All things that the ICU patients are going to experience. And the other thing with IV phenobarbital, I think it's going to be around more. I think as its use with alcohol withdrawal has become more common, I think it's just going to be available more. So as another option to kind of give, I think that's a great highlight. So let's shift gears here into refractory status epilepticus. And you mentioned there's debate over whether there's a time component or not. But my question is, how long do you wait after you've given your emergent kind of ASM to say you've failed, you need to get another second line agent, and you've now kind of entered that refractory period? What's that time frame look like?
So it depends on the guidelines that you're looking at. They do have some associations with like stabilization phases and emergent phases and whatnot. I think, again, it comes back to really focusing on rapidly progressing through your steps, so to speak. So having that second and third agent actually coming in mind and having that literally in your pocket if you can, before, right? And so what was nice to see actually when we looked at the ASCET trial, those that did have early termination from that first agent typically had it within 10 minutes, right? So I would say a good chunk of patients, if you properly dose them and you're using the right agent for in that sense, right? Um, Within 10 minutes, you should already be thinking, what's next? What is the next thing on the horizon? What should I be thinking about? Are we going to have to intubate this patient? Are we going to go to the anesthetic? Are we gonna try to avoid intubation because maybe this patient has a difficult airway or really something in terms of respiratory compromise that might make it difficult to extubate, maybe some sort of pulmonary fibrosis or something like that, right? These are considerations that you're trying to take into account when selecting what you're going to choose and how fast you're going to choose it.
Do these patients always get intubated at this point if they've gotten a few of these agents? Is that just going to happen, or will there be patients who might be in refractory status that are not on a ventilator?
Yeah, I mean, so you'd think that eventually with all these agents that we're giving them, right, like the neurogenic, I guess, inhibition that's occurring with all these benzos and barbiturates and ASMs, that they would be so snockered that you'd have to intubate them. But that's actually not the case, right? I would say more often that you're going to intubate a patient because we're not treating them appropriately than treating them appropriately. So what we found is typically underdosing for these agents has led to more intubations than not. So just because they aren't being managed from the agents that you've selected doesn't necessarily that mean you're going to intubate them, but there is a high likelihood that they could get intubated if they are still in refractory status.
Jason, we need to shout that from the mountaintops, that appropriate
Absolutely.
dosing, because how all of us have experienced this, right? Well, I'm worried, right? I'm worried about their neuro. I'm worried about their airway, right? And the argument is if you appropriately dose it, you are worrying about their airway and you are treating them. So thank you for highlighting that important PSA for us. The other big thing I feel like kind of took through a little bit of the neuro world by storm, the pharmacist first authored Lauren Kimmons, the Neurocritical Care article describing the safety and efficacy of ketamine without intubation in refractory status. And I think a lot of what I heard is people were maybe doing this more, but this is one of the first kind of pooled analyses and kind of positive research showing, hey, what we are doing is probably helpful and maybe there's more here. So it was kind of really cool to highlight and kind of see that, hey, maybe there are options that we can use that won't require necessarily straight intubation.
Yeah, I think this is absolutely a wonderful idea, actually, especially with the reimplementation of, and the resurgence of ketamine in the ICU, specifically in this case. If you can avoid an intubation, that's amazing because, all the downstream effects and complications associated with patients that become intubated, right? So we do know that there is data to support ketamine drips in patients with that are not intubated. However, I like to say the devil is in the dose. If you start to get into a little bit more of that aggressive doses that we're typically seeing, you might not be able to continue this therapy without having to intubate that patient. And you remember, ketamine can be a little bit of a funky drug where you have an altered mental state where it makes look like their GCS is less than 8, and really they're still protecting their airway and you're okay. And so that's what's actually wonderful about this drug. If you have a lot of providers that are comfortable with it, they're a little bit more aggressive, and then we'll know when to intubate these patients when they do start losing that airway protection, right? So I did notice that when we analyze, by the way, shout out to Lauren because this is an awesome, awesome study. I love the fact that we still continue to do loading doses that would be technically used in status epilepticus, albeit it was in the lower end. But it makes sense. We're using it in the sense that in the sense of not intubating this patient. But it was actually interesting that these patients didn't necessarily have to have such profoundly high doses that you typically see in ketamine utilization. Now, we're talking about doses that you typically will use for analgesia or even, agitation in non-intubated patients. So it's actually rather interesting that those doses seem to work for some of those. Now, it was a smaller study, but it is a hypothesis generating aspect for sure.
I thought in the neuro world, 28 patients is like mid at least.
You're not wrong. You're not wrong. We like to get above the 30 mark, you know. So
Okay,
I'm just
okay, we get
kidding.
into it. So, thinking about the big three of our continuous infusion IV, I think of sedatives, which you'll see IV anesthetics, benzodiazepines, propofol, or pentobarbital. Is there a first line agent, either guideline recommended or pragmatically, that we use out of those big three typically?
Yeah, I think it's important to recognize that we do have the classic big three, if you will, with that being the benzodiazepines, specifically midazolam, propofol, and in the States, pentobarbital, the barbiturate. Um, there isn't necessarily an agent that is selected one over the other. However, there are considerations to take into account when you're selecting these. Now, I will say that you had mentioned that JAMA neurology study, that systematic review that looked at continuous
Yeah.
in IV anesthetics. That kind of supplemented way back what is used to be what was highly cited in 2022 by Clausen colleagues. What was the previous one that compared the three agents that showed no difference between the two or between the three agents? And it kind of just said the same thing again. It said, hey, we really don't know which agent to use, but we do know there are a lot of adverse effects associated with each of them respectively. And we do know that there is provider preference actually with mostly people using midazolam and then next being propofol before jumping to a barbiturate. And I think that kind of lends itself to what I was alluding to about the adverse effects. There are a lot associated with pentobarbital utilization. That's not to say that there aren't side effects associated with the other two, but I think providers are a little bit more comfortable with the first two agents of being midazolam and propofol.
They just use those two more agents, right? You're gonna be more comfortable with them. You're gonna be, yeah, we know propofol's got those side effects, but they're a little more integrated into what we know and how we use it versus pentobarb. It's almost like when we use it, there's like a literal checklist because there's so many unique things that you need to take care of. It's like, oh, make sure they have some sort of NG or J tube because it slows gastric empty, all that sort of stuff.
Yeah, I mean, and not only that, think about the ability to procure the agent, right? You got a compound of pentobarbital, you're not going to have that in the Pyxis. Most of these agents nowadays, from an ease of use and accessibility standpoint, we're going to be using premix agents, whether it be midazolam and propofol.
This episode of Pharmacy to Dose is proudly sponsored by Chiesi. Providing innovative pharmacologic therapies for over 85 years, Chiesi is committed to supporting the clinical pharmacist community and the patients you serve. To learn more, visit chiesi.pharmacytodose.com. Talking about kind of probably the two agents that we would see in PADIS use, right, like midazolam and propofol. Just to set the stage for the listeners, how does their dosing differ? Because yes, they're both used in those disease states, but they're used very differently.
Yes. Like I mentioned before, the devil's in the dose. And one of the things that I often see, unfortunately, when you walk in the first thing in the morning and you say, hey, you got a brand new status epilepticus patient, I say, okay, let me see what dose they use this time, right? And unfortunately, most of them are pre-selecting that PADIS guideline order set or protocol or power plan, what have you, whatever your institution uses. And that leads to really low doses. And not only does it lead to low doses, it leads to inappropriate initiation as well. Rarely do I see an agent, if they're using that order set or that protocol or whatever, what have you, a proper loading dose, right? And so each of these patients should be getting properly loaded based on the agent that they're using, whether it's, 0.2 mg per kilo, or if it's 5 mg per kilo load, or a 2 mg per kilo load each time you're titrating these particular agents. And so I think that's one thing to take into consideration is the fact that these are each time you're going up or you're starting these agents, you need to be using higher doses, higher loads. And for instance, Versed, right? I'm not sure at your institution or your practice sites if you're using a weight-based dosing or if you're using flat dosing.
In
Well,
in the
yeah,
in the
yeah.
static weight-based dosing. to help
Yeah,
differentiate it.
exactly. So I think it's important to recognize that these agents, when you're using them, are going to be always dosed from a weight-based perspective. And that being said, you're going to see some crazy high doses that you're not used to, right? Like upwards for midazolam, for instance, the max dose that has been shown, I think, was classically 2.9 mg per kilo per hour. There were a few patients that did get up to 3.3 mgs per kilo per hour, but that's whopping doses, right? You're pumping through that 50 per 50 bag, and that's something you got to consider as well. But you know that you're doing the right thing when you're changing that bag every 30 minutes or every hour, and you're saying, hey, maybe I need to compound something. That's when you say, okay, I'm doing a good job dosing for refractory status epilepticus. Same thing goes for propofol, right? You're using these agents, um, and it's classic. Some people I have wide awake on 50 mics per kilo per minute. And if you're using this as some sort of therapeutic coma or burst suppression modality, and we'll get into some of that terminology, you're going to likely supersede that 50 mics per kilo per minute. It's not uncommon to see upwards to 200 mics per kilo per minute. Now, I know there are a lot of discomfort once you start superseding the 100 mics per kilo minute marker. But yeah, these are huge doses, right? Same with the ketamine. I Ketamine, when you're using it, classically for anything that I've seen, when you're using it other than status, you're seeing mics per kilo per minute. Reference points usually will change those units because you're getting such large doses to mgs per kilo per hour. For ketamine, I'm going all the way up to 10 mgs per kilo per hour. I've even used 15 mgs per kilo per hour. There has been a case series or case report using such high doses. Yeah, these are huge doses.
And there's a 2014 neurology study I always like to reference that showed that when you use that higher dose midazolam infusion, this was 0.4 mg per kg per hour, so still maybe on the lower side versus 0.2, the 0.4 group had a quicker termination of them, even signals of reduced mortality, probably because you're terminating them quicker, but still. Now, when we're thinking of benzos, you keep mentioning midaz. That's what you'll see in the literature. Why don't we see lorazepam in this? They're both benzos, right? And actually, lorazepam is our first line for what we use IV. So why don't we want to use it here?
Yeah, so I mean, in reality, if we were just using push doses, it would make sense from a pharmacological standpoint and the duration of action and the lipophilicity of differences between those benzodiazepine agents. It would make sense lorazepam would be our choice, right? But unfortunately, the solubility of that agent does require propylene glycol. And so we do know that continued utilization for most of these patients, they're going to be at least 24 hours at minimum. And it should be at least at minimum. And they're going to be receiving quite a bit of high doses and volumes of propylene glycol, I guess, but propylene glycol ultimately leading to possibly like a lactic acidosis, metabolic dysregerangements, and things of that nature. And so, because of that, we've switched over to the midazolam as the primary choice because it does not have to have that particular emulsification.
So we're talking about, right, we're using different dosing regimens, different kind of combinations of treatments and things. What are, you mentioned the order sets and things. What are some medication safety principles to keep in mind with these agents, especially the agents that will be used in different areas, but obviously with very different doses like you were just describing?
Yeah, so there are a lot of different adverse effects, and that's kind of how I pick my agents, right? So I think about a lot of the things that you're going to have to take into consideration. So for midazolam, for instance, and really for all these agents, you're going to have hypotension as a concern. These are going to be really high doses. One thing though is that's important to recognize is the fact that you can actually get tachyphylaxis due to prolonged exposure. And so once you start telling yourself, maybe I'm not seeing that type of suppression I once had, or maybe you're seeing a little bit more frequency on the EEGs, you might start considering switching your agent because the person is getting used to it essentially, right? Your body's getting used to that particular exposure of that drug. Also, based on its volume distribution of the drug itself, the accumulation can occur. Obviously, any sort of respiratory depression for any of these agents as well. So those are some of the things that I think about with midazolam. But one other aspect I think about is the active metabolite. So it's not really dialyzable or anything like that. So maybe someone is an AKI and they've been on a long time. So, and you're actually trying to see if they're going to wake up. And maybe they're not waking up and you don't see seizures on your EEG and they're not clinically seizing. Well, it could be the fact of the midazolam, and maybe that's someone you try to avoid it, that they're in fulminant, AKI, and that can help you select your agent. As far as propofol goes, this is the agent that most people will, think about propofol infusion syndrome or your PRIS. So these are your typical agents. Anything, depending on what you're looking at in terms of the literature, anywhere from 80 mics to 100 mics per kilo per minute, you start to get a little worried about this particular syndrome. It's pretty profound. It can be deadly. So you're checking your lactates, your CKs, all those particular monitoring parameters. Additionally, it being emulsified in lipid emulsification, you're thinking your trigs. So you should really get a baseline. Typically, I'll get it every 3 days. If I'm using this agent with someone with a very high baseline, one, I probably wouldn't have chosen it in the first place. But I'm usually using a cutoff of 500 and then tapering it back while also adding another agent just so I don't get into any sort of side effects from that particular aspect. Or for the big three in terms of pentobarbital, this is my last go-to agent. I call it, the last hurrah because there are so many side effects associated with this. I mean, this too is also solubilized in the propylene glycol, so it's associated with toxicity as well. I mean, I don't know any time that I haven't had to start a pressor when using pentobarbital. It's a part of our order set that it is pre-checked that you have it. You might as well have it in hand because you're probably going to drop their pressures.
It gets brought up with it. It gets brought up with your initial
always.
dose. Yep.
Yeah. So it's kind of the status quo. Say, hey, I'm going to start this. Okay, and it makes sense. You're doing its profound metabolic suppression with this particular agent. It's got propylene glycol. Of course, it's going to drop your pressures a little bit. One thing that you mentioned way earlier in this podcast is the fact that it can cause like an adynamic ileus. Upwards of 30% of these patients are going to have it. So you're going to want that enteral access, appropriate enteral access. You're going to want to make sure that you have a good bowel regimen, because once they have that, unfortunately, it's a transient thing that can last some time. And I've seen some gnarly, ischemic bowels from this, unfortunately. Yeah. And then I don't know, for ketamine, I don't know if you want to talk about ketamine, but ketamine also, same thing. One of the things that's nice about ketamine, as we mentioned, is the fact that you can use it in non-intubated patients, technically. But it does cause issues like emergence reactions. One of the most common things that we think about is the fact that it does cause cardiovascular manifestations such as hypertension. It does, from an exposure standpoint, have a risk to cause adrenal insufficiency. So that's something that you want to take into account. Maybe someone who's also septic, that's completely depleted of, your endogenous catecholamines, maybe something that you don't want to select for.
So we'll still talk about, super refractory here in a second, but how do we, while we're still on the topic of these medications, so how do you wean off of them? What's that process? Because that's certainly, when these are used longer term, and when we're saying longer term, right? These aren't 1-2 days. We're talking 1 to 2 weeks sometimes. How do we wean these off? That feels a little complicated. Maybe job security, I'm sure, but what's some general principles on how we do that?
Yeah, it's important to recognize that weaning is going to happen in a multitude of fashions and at different times, right? So guidelines recommend typically that minimum, once we start these agents, you need to be at least on this agent for about 24 hours and up to 48 hours. Now, oftentimes, we won't be able to wean just because we haven't controlled for many of these patients because they've developed, progressive seizures, unfortunately. Now, let's say we're at the stage where we finally got the clinical seizure suppression or burst suppression that we wanted using these anesthetic agents. I think it's important that you take into consideration a multitude of things. One, you're taking into account that you're at your goal, whichever goal that may be. Two, the agents that you've selected are at steady state. And that's so any sort of anti-seizure medication that you use not that are considered to be at a therapeutic concentration, and maybe you don't have therapeutic monitoring. Maybe you do. So if you have therapeutic monitoring, take that into account. Make sure you're at a therapeutic level, or at least anticipated to be at therapeutic level during the weaning process. And if you don't have one of those agents where you can get a level really quickly, maybe take into consideration the half-life of the drug, right? And so once you think that you're at steady state, whether it's actually, just assessment of half-life or actually therapeutic drug monitoring, then you can consider dropping your medications, your anesthetics. And so unfortunately, I've seen a whole slew of how providers come about this, right? Because there isn't really strong literature on it. And if someone's been on an agent for a very long period of time, I would probably say it's pretty bad form or poor form to just drop that continuous agent and just say, hey, let's see how they do, right? It's not going to go well, right? So what you should be doing is doing some sort of percentage on an hourly basis, or, there is some citations that you might have seen across the literature, or maybe my cohorts might have seen, that are often referenced. And it's the Ligral paper in 2017, where they actually came up with a couple percent basis. And I use this in my practice typically. Now, I don't do it to the full T because I just try to oversimplify it. But basically, what you're doing is you're taking a percent reduction every 3 hours. So depending on the agent that you're using, right? Like, for instance, what they reference for midazolam, if I was, for instance, on 20 milligrams an hour, let's say, of midazolam, I would do a 50% reduction of that every 3 hours until I have whatever goal that I'm seeing or completely off, right? For pentobar propofol ketamine, they use a 20% reduction every 3 hours. And so I kind of stick with the 20% just to make it easy for everyone, consistency, because they might forget if I'm not on the floor or something, just to make sure it's consistent across the board. Now, I will say that sometimes it does give a little bit of anxiety for our nurses because there's random doses that kind of make it hard to titrate by. But at least it gives them an idea saying, hey, we need to be more consistent on the progression of the reduction of this agent rather than just 50% off. And while you're doing so, you're taking a look at your EEG, you're using your clinical assessments. So it's really important that what we're doing is we're taking into account what the goal is, whether that's, electrographic seizure cessation or burst suppression, right? And maintaining that as you're going down on these agents rather than cold turkey stop. And what we found in these patients, and recently in that JAMA Neurology systematic reviews, that we've had a marked improvement in not having to re-implement that continuous IV anesthetic. I think mostly because we're doing a better job of, loading them up with the right ASMs and also weaning these medications off rather than just cold turkey turning them off.
Really good advice. Now let's kind of shift into the super refractory side. And in this, one of the things that'll be happening in all of these patients, or should be, is continuous EEG monitoring. So we've had a EKGs for PharmDs, quick highlight. Let's have a neuro version, EEGs for PharmDs. Any tips or pointers? Of course, we're not going to be experts, but things to look for, or classic phrases that would that would help us when you see the reports come out, Q12 hours or Q shift, whenever.
Yeah, in no way will I would say I'm an expert in evaluating EEGs or any sort of recordings. I definitely leave that to my epileptology colleagues, my neurointensivists and neurologists. But they have helped me read the report and learn how to read the report and actually look on things actually on the imaging. And so what I would say as a primer for those pharmacists are hoping to kind of just get a general basic understanding of EEGs is much akin to like our EKGs, and understand that we do place electrodes on the body, and this obviously on the cranium. So it's a lot more electrodes. Unfortunately, it's not directly on the brain. There is, artifact that will come through the skin, through the skull, and then maybe even through blood, depending if they have any sort of, intracranial process. So it's really similar to that aspect. We do have a way I guess what we refer in neuropopulation a montage of how we place those electrodes in certain positions that can give us certain readings for status epilepticus. And what we're looking for really is a clear, depending on what you're doing with that EEG, is looking for kind of these spikes and amplifications and frequencies, right? There are different frequencies and at different time points in different locations. That's something that's a little bit more complex, but to really dumb it down or really oversimplify it is I like to think of it when you're looking for seizures, you're thinking of it almost like a wave in the ocean, right? There's a progression of this kind of rhythmic activity that goes up and up and up, and you get really high spikes in amplitude, and eventually, hopefully, it comes back down. Those are the ones that you do have seizure events, and then they're breaking. Now, in our cases that you have super refractory or refractory status, it just looks like one big old lie detector, right? You're lying like your teeth through your teeth all the time. It's just going on. That's kind of what I would like explain to someone that's basically just seeing those types of amplitudes and frequencies. It really looks like a bunch of squiggly lines that are very frequent and condensed. And so eventually what we would do is hopefully, depending on what your target goal is either break that seizure or cause complete suppression or attenuation of those bursts that you'll see. Now, what I will say is one of the more important parts, I think, rather than just looking at it, is understanding the reads, as you mentioned. Now, that's what I do majority of the time, right? I look at, hey, what did my epileptologist tell me? And so what I'm looking for clearly is there seizures present? They will clearly dictate that. It's important that they do that because there's electrographic seizures that are reported on the EEG as a surrogate. They'll also talk about the different types of epileptiform discharges. And so it's important to know the differences in that because there may be a more likely event to occur depending on what you see or what's being reported, right? For instance, you'll often hear generalized periodic lateral discharges or periodic lateral discharges or general periodic discharges, GPEDs or PLEDs. And what's been shown in the literature is actually when you see those GPEDs, they do have a higher propensity to actually develop into seizure-like episodes or seizures. So maybe that tells you to be a little bit less aggressive with backing off and just be a little bit more cognizant and have a slower wean, or maybe you need to ramp up your other ASMs. You'll also see terminology where you see concerns with ictal versus interictal continuum, the IIC. That's a huge contentious area that we can't get into, that we could probably have a full podcast on its own. But what I like to do when I see that, I'm like, ooh, okay, let's have a conversation, right? As a pharmacist, I want to have that conversation with my team and say, what are your thoughts? Clinically, I think this patient is not doing any better, even though we don't technically see seizures, but there's an IIC, right? That interictal continuum. Maybe we still remain aggressive. And so that's really something I like to tell my learners, hey, if you see this, let's have a conversation as a team, because there's no clear-cut answer for this. It's more, let's take it basically as a surrogate and apply it to the clinical picture and see what we need to do from there. But it prompts that discussion because as pharmacists, we can make recommendations on the doses or add agents when we see these reports.
So in this realm, our goal of treatment is cessation of electrographic seizures, right? Also known as burst suppression. But help us understand the difference in burst suppression and seizure suppression, because I'll see both terms sometimes used, but I don't think they're interchangeable.
Yeah, I mean, when I first learned this, I was very confused because I thought it was the same thing, right? They're actually not. And it's what most institutions will do is have a clear protocol based on the institution. Some will deviate from that. So it's important to recognize that there are, in fact, different types of circuits that we use. So we did mention the most important thing that we're doing is using an EEG as a surrogate, right? That is not necessarily electroclinical seizure suppression. We are looking at three different things, right? So what I like to think about when we're using this as a tool, we use EEG monitoring typically in three types of methodologies. And this is specifically for the EEG specific targets. So It's either using it as the cessation of an electrographic seizure, as you mentioned, and the emergence of a therapeutic burst suppression or attenuation of a certain pattern. And then lastly, and more uncommonly, is an isoelectric curve. I'll say that I haven't had in my practice, I haven't practiced, in a super long time, but I have not seen that as a modality of a target for us. So it really comes down to really the breaking down of the electrographic seizures and or therapeutic burst suppressions. Unfortunately, there hasn't been any sort of great data to support any of these methods over one another. I will say that the majority of practice sites do typically use burst suppression as the modality. And the reason being is because I would say it takes a little bit more of a keen eye to by your readers, right? So your epileptologists, neurologists, some centers don't have epileptologists, your neurologists that are reading your EEGs. You need usually those particular specialists to help guide you. And so you can't really make a lot of action with what you're doing in an acute manner, right? So with burst suppression, you can really train people to look for essentially a flat line and then a spike. That's your burst, right? And so it's important that you have training for those individuals that will be titrating to those particular target models, since it is a unique set of skills that you need to have, but it's something that's a little bit more manageable. So our bedside nurses, actually at my institution, are the ones that are going to titrate based on burst. Now, if there is a patient that is a little bit unique, the physician will take ownership and just say, "Hey, call me when you have this, or this," right? And so those types of things are going to be key communication points between the nurse and the provider. But more often than not, in our center, in most centers, I would say burst suppression is the most common. And I think that comes a lot to a recent guideline that actually mentioned it. I think it was the American Clinical Neurophysiology Society that defined what burst suppression would be. And so, interestingly enough, that still is confusing for us as practitioners, right? What is burst suppression? So we're trying to find what that really is. Is it a set number or is it a percent reduction? Now, that society that I just mentioned actually references anywhere greater than or equal to 50% of your baseline reporting, which, I practice at centers that give me a flat, give me 4 to 10 bursts only within a minute or per page, right? And it's important that you're, as a clinician, you're understanding what you're looking at and you're going into the room. Because every status patient, I go into their rooms and I look at the EEG monitoring. I'm saying, hey, what is the page I'm looking at? I'm looking at either 10-second intervals or I'm looking at a full minute page. So it's important that you take into consideration. But yeah, I think it's completely different, but there's not one right answer. I will say, even if you do look at the systematic review that we're often referencing here, you can even see what type of monitoring modalities they're using or target surrogate endpoints they're using. Some have mixed, the majority do have bursts, but some have just electrographic seizures. So I think the key point here is just knowing what your target is, communicating that with your team, and then understanding if you're achieving those targets.
So the last treatment we haven't really hit on is our inhaled anesthetics that you'll see at this point, most commonly used in the OR, but you will see as a treatment option listed here. So these are given via inhalation. They're used primarily in the OR. Will we see these used? Are there any kind of considerations for us if we're going down the inhaled anesthetic pathway?
Yeah, really cool concepts. I will say our European colleagues tend to use this a little bit more, and that's where the majority of our data stems from. Personally, I haven't had the pleasure, or I guess maybe the anxiety of having to dose or deal with isoflurane specifically, because that's the agent of choice that we would typically use for inhaled anesthetics. But the things that you need to consider are a lot, actually. So first and foremost, is it safe, right? So you need to make sure with any agent, when it comes to pharmacotherapy, is the agent being administered properly being administered? So do you have the right setup? Do you have the cartridges? Do you have the right cobalt machine? Do you have the different types of machines available? Do you have the training for your respiratory therapists, right? So there you have to have a lot of coordination. You're taking this into consideration, and then in of itself, the exposure of these gases can be lethal or gas volatile, really, and harmful. Is it, in and of itself a hazard. So there are a lot of hazard considerations to take into consideration. But more importantly, just from if you have that all set up and ready and you're ready to go, you need to take into consideration the patient, right? So that patient might have an pneumonia, they might have ARDS, they might have pulmonary fibrosis. These are all things that you really have to take into consideration. And interestingly enough, even though it is an option, there is data to suggest it can actually possibly be neurotoxic. Now, the mechanism is really through animal models. They think that the drug, high doses of the drug, if not controlled for, can actually cause induction of these apoptosis of the neurons.
So we hit on the medication safety principles kind of clinically from the bedside with our titration principles and things. But one of the other key difference you even highlighted in your example is operationalizing our use of these. And so what are some key maybe tips or tricks as we are looking to improve, whether it's Operation Central Pharmacy, the EHR, but how we're able to more safely use these kind of high dose agents that come with lots of side effects?
This is something, unfortunately, I've had to personally deal with, right? And this comes down to being able to provide the medication as quickly as possible, yet in the safest manner. And many of these agents, unfortunately, are considered controlled agents. And so getting them to the bedside even makes it way more markedly difficult because you have that central pharmacy, right? Or even if you're decentralized, do you have that control in that decentral pharmacy? Most don't. Most institutions have a narcotic vault where then you have to pull it. Maybe if you're as large as our institution, over 1,100 beds, you're once that narc vault's been pulled, you have to wait another hour before you get back to it, right? So those are the things that you have to take in consideration because if time is one of the most important things in this setting, then you need to know how you can operationalize it in a way that gets it to the patient's bedside as fast as possible. And so one of the things that we take in consideration, and we have mentioned is it possible to get the drug at the ADC, your automated dispensing cabinets, right? Whether you're using Pyxis or not, right? That's what I use in our institution. But if we were able to get it in a formulation that gets it a lot more accessible, that still maintains that control and that allocation, then that's the thing I would do, right? And set it up for the ease of administration. Those are things that I like to take in consideration. Now, unfortunately, some things that you have to take into account in terms of compounding, like your phosphanatoin, those are going to be a little bit more difficult, right? And so is it possible to create, vials that have, X amount of drug in it that gives you less manipulation, less prone to error? Unfortunately, we don't have that option. So getting the things that you do have, less error-prone compounding, such as your push dose vials, or maybe even using Keppra premix bags, right? So that actually is quite easy, and that's what we'll do in our institution if we don't have just vials laying around, because who knows, if you're loading someone with Keppra vials at 500 milligram intervals, that 4.5 grams is going to be quite a bit cumbersome. That nurse is not going to like you very much. And they're going to be just sitting at the bedside saying, hey, this pharmacist really needs to get fired. No, so if you're using a premix bag, like we do, you can use sequential administrations, like a 1,500 bag, back to back to back, and just 999 it essentially wide open, and then let that infuse. The nurse can do other things because they're going to be running around because this is a medical emergency. So it really frees their hands up, gets the drug to the bedside really quickly, and it's actually seamless. So thinking about things like that really can make a huge difference. One, it's going to be safest for the patient. Two, it's going to be quickest to the patient. And three, your colleague's going to love you for it because it's just going to make it a lot easier.
That's really good advice. And especially things that until you go through it, you might not have had to think about before. So that's really good help for a lot of people listening that may be looking to change or modify their operations with that. So part one, the status epilepticus, we were waiting on, ironically, the results of the ESET study. You go back and look, we didn't have those yet. So any research coming? What about guidelines? 2012 NCS guidelines, 2016 AES. Where are we with new either publications or statements or guidelines?
They're at least from my knowledge and in the recent review of some of the guidelines and societies and organizations, there isn't a lot, unfortunately, just because of the nature of the disease state in of itself. I will say the American Epilepsy Society has really revamped their website and has broken down a lot of the different types of subgroups that might be really useful, whether it's like the treatment-resistant epilepsy, like with your new anti-epileptics. So they're incorporating a lot of the newer ASMs or AEDs into therapies and showing what you can progress to or use in some of those different settings. So I'd really recommend to the listeners to say, hey, take a look at some of those more recent guidelines. There's a couple of those that are from 2018. A lot of the data is really with some of those nuanced or research nuanced agents, whether it's on autoimmune data or utilization of those refractory treatments such as high dose steroids, rituximab, those agents, mostly case series. Unfortunately, I don't have anything in the horizon that I see that is like a randomized controlled trial.
Okay, we're gonna have to keep waiting here. But Jason, this was awesome. Talking about a topic that is really hard to, if you try to research and find things. So not only summarizing what's out there, but from practice experience and things. So close us out when we're thinking about management of status epilepticus, specifically kind of refractory and super refractory. What are three of your biggest take home points for the listener? Things that they got to remember when we're treating these patients.
I like to say that the most important thing I would have to say regarding status across the board, whether it's just status epilepticus, refractory status, or super refractory, is being aggressive. Don't be afraid to be aggressive. And what I mean by aggressive, I think of three things. I think be aggressive in your timing. Get us there as fast as possible. Figure out a way to do it, whether it's operationally, physically, whatever you need to do, get the drug to the patient as fast as possible. Be aggressive with your dosing. Don't be afraid to dose patients aggressively. Don't use the agents that are meant to be for PADIS. Those are wrong, right? Be aggressive in your dosing. And then be aggressive with escalating care. If it's not working, move on, right? Move on to the next dose, move on to the next agent. So be aggressive in timing, dosing, and your escalation. Those are the three things I would say in terms of being aggressive. The next thing I would say from a big take-home point is ASMs equal DDIs, right? If you're using the ASM, your anti-seizure medication, you should be really ready to prepare for any sort of drug-drug or drug-disease interaction because you're going to run into inhibitors, you're going to run into inducers, and this is just going to make, this is what you get paid for. You're going to be able to help facilitate better care and better therapeutic levels and, avoid any sort of drug-drug interactions that may lead to harm. And then lastly, and we mentioned a little bit, is therapeutic monitoring, whether that's therapeutic monitoring of the TDM itself, the drug level itself, or the side effects that you can classically see with it or prevent. So therapeutic monitoring is a must when you get to this, especially when you get to these really high doses and really dangerous agents. These are not, things that are benign. These are very harmful agents if, going unabated and not really being monitored and just going really heavy, aggressive dosing, as you should, but if without any sort of clinical monitoring can lead to harm as well. So it's really important that we be aggressive, we check for drug-drug interaction and drug disease state interactions, and we're always monitoring whether it's drug level monitoring or just looking for any sort of adverse effects that are associated with these agents.
Jason, this was awesome. Listeners, reach out to him. Remember, the brain PharmD. But very appreciative of you coming on, sharing your time, talents, and expertise for part 2 of status epilepticus. Greatly appreciate you, Jason.
It was my pleasure. I'm really happy that I had the opportunity. Thank you so much. And I hope we continue to progress care in this area.
Thanks again to Jason. What a great, great episode. A reminder, let me know what you think at PharmacyToDose on all your social medias. PharmacyToDose.com is the website address where, of course, you'll find the reference list featuring all the articles and guidelines and things we talked about. Of course, that's in that podcast episode description as well. Clickable PDF link. And feel free to send me an old-fashioned email, pharmacytodose@gmail.com. But until next time, I'm Nick Peters, and this is Pharmacy to Dose, the Critical Care Podcast. The podcast provides general information only and does not offer individualized medical or professional healthcare services, including pharmaceutical advice. The contents and materials in the podcast are not intended to be a substitute for inpatient pharmaceutical advice, diagnosis, or treatment. Use of the contents and materials on the podcast does not constitute a pharmacist-patient relationship. As a result, the information in and materials linked to this podcast are applied at the user or patient's own risk. Users and patients should consult their physician or personal healthcare professional. Users or patients should not ignore or delay seeking care because of something they heard on this podcast. In case of an emergency, the user or patient should contact their physician, call 911, or go to the nearest medical emergency facility. The views and statements expressed on this podcast are those of the host and guests and should not be interpreted to reflect the official position or policy of ACCP or the Critical Care PRN. ACCP and the Critical Care PRN disclaim any and all liability or responsibility for any direct, indirect, incidental, special, consequential, or any other damages, including without limitation, loss of profits arising out of any use of, reference to, reliance on, or inability to use the podcast, its contents, and materials.